Hello, this is Allan Schwartz, DDS CRNA, and I would like to welcome you to our course, Essentials of EKG. This course is based on the textbook, Rapid Interpretation of EKGs, which is an excellent and easy to read book by Dr. Dale Dubin. He taught the course of EKG so simplistically and easily to understand that I really recommend it if you want to go further with your studies on how to read an EKG and get into a lot more detail. I'm going to be using a lot of repetition in the course slides that you're going to be viewing. The repetition is necessary to make sure that you understand and diagnose the differing electrocardiograms that we're going to be looking at. There's a number of different ways to look at it, and we're going to go about a systematic approach. So hopefully this will be hammered into your head, so to speak, so that you understand what it is that we're talking about. Welcome to the Essentials of EKG. The disclaimer is to tell you that it's a general guide to the way that I learn things and the way that I present things, but there's other differing opinions and other sources for you to be able to obtain knowledge on how to read an EKG and how to interpret it. And I hope that you'll have a chance to use those. Let's talk about the learning objectives. We're going to first discuss the anatomy of the heart. It's going to be essential to know that so that you see the electrical system associated with that anatomy. We're going to talk about the basic cardiovascular circulation. And we're going to discuss the cardiac anatomy, as I said, and how it relates to the electrical, the signals that we're going to see in the EKG. Then we're going to be talking about basic rhythms, how to recognize them, how to use the systematic method to be able to diagnose them, and then go through and look at some common dysrhythmias, some of which are lethal dysrhythmias. We're going to be using the term dysrhythmia quite a bit instead of arrhythmia. Some people will use them in either place. Arrhythmia to me means that there is no rhythm. With a dysrhythmia, you've got a dysfunction in the rhythm. The electrocardiogram is an electrical heart record or a display. It's either on the monitor, it can be on a strip of paper. We will be using the terms ECG, which is electrocardiogram, using the English cardio, where it was called an electrocardiogram with the letter K. The person that discovered it is quite an interesting story, and I want to share that with you. His name is Wilhelm Einthoven, and I'm going to be turning on a movie. Hopefully you'll have a chance to see this when you're looking at your slides. You'll see that his 159th birthday was just very recently, and he discovered the electrocardiogram in 1895, and he received the Nobel Prize for it in 1924. It was a big opening and an important thing to be able to look at the patient and safely diagnose them, see what's going on with the electrical activity of their heart. So his 159th birthday was May 21st of 2019, and as you can see, Google did a little movie on him. So he is 163 years old, he would have been today. In that, you will see in that picture from Google that his right arm and his left arm and his left leg are in a bucket of water, and then there's going to be wires from each of those three areas. Those are buckets of water, and they put that signal that was received from his beating heart through an electrical amplifier, and then it caused a wire to wiggle or a needle to vibrate, and it wiggled in a persistent pattern, and it's totally related to the beat of his heart. And then he shone a light through some moving paper, and that's where we obtained the diagram or the first images of an EKG. that wire that wiggled was in a magnetic field that had holes in it. A light was shined through onto photographic paper, and again, that tracing came out with the familiar waves that we see in an EKG that we're going to be talking about in just a little bit. Notice that between his right arm, his left arm, and his left leg is what's called Einthoven's triangle, and we still use that term to this day. So the important concept here, as we've already alluded to twice in our introduction, is that when we see an EKG, it is only an electrical activity. It does not mean that the heart is beating. We would have to feel a pulse for that. And due to the fact that we have electrical activity and maybe not a physical heartbeat, that is a situation for ACLS, and that is called pulseless electrical activity, or PEA. And we use the medication epinephrine to be able to hopefully get a pulse back again. But there's only electrical activity, and it can look just like a sinus rhythm. So PEA is pulseless electrical activity, and it can mean also push epi again. So we do that every 5 minutes, and we of course are doing CPR. Let's review the anatomy of the heart. The patient is going to be looking at us. We have the right atrium, the right ventricle, the left atrium, and then the left ventricle. And they each have different pumping abilities and pressures that they create. So the heart is really two pumps in one. The right side of the heart is pumping to the lungs, and it is considered the low pressure side of the heart. The left side of the heart is the high pressure side of the heart. It's much more muscular, and it's pumping through the aorta to every living cell throughout the entire body. The lungs on the right side cannot see a big, heavy, strong, normal blood pressure that we would establish with the left side of the heart. Remember that blood pressure is going to be the force of blood that circulates all through every organ, every cell, every second of the day throughout our body. Systole definition is the physical pumping of the heart. We're going to have that circulation pumping from the left side to the major organs, such as the lung. The brain commands a lot of circulation, the kidneys, and then the liver, taking of blood from those major organs. Diastole is the actual filling and resting stage while the heart is getting ready to beat again. It also is the time that the coronary arteries have a chance to provide oxygen and take away any waste products, and it also provides nutrients to the heart muscle itself. So in certain people with coronary artery disease, a heart that's beating very, very fast, that's needing a lot of oxygen and blood and energy, may not be getting that if we don't have enough diastole time to be able to circulate to the coronary musculature itself. The circulation to the coronary arteries, there's the left coronary artery, the left circumflex artery, the right coronary artery, and the left anterior descending artery. We left that one for last because that's the one that is nicknamed the Widowmaker. So if that is blocked, heart muscle will die very fast and the patient will die unless some intervention is done. Here are the valves of the heart. On the right side, we have the tricuspid valve. So of course, we're going to have three cusps to that valve going from the right atrium to the right ventricle. Then we're going to have the valve that goes to the lungs. The main valve is called the pulmonic valve. You see the word pulmonic, pulmonary there. And that's going to be, again, the low pressure side. So deoxygenated blood is going to circulate from this right side to the lungs to be able to pick up oxygen and deliver carbon dioxide. Then we have the mitral valve. That's going to be the valve that is in between the strong left atrium and the very strong left ventricle. Look at how thick that muscle is in the left ventricle compared to the more thin, more delicate muscle on the right side of the heart. It's from the right ventricle. The aortic valve takes the blood through that valve, through the aorta, and then all the way through to the skull, all the way down to the big toe with all of our oxygenated and blood with nutrients in it. There's a concept called atrial kick I want you to know about. The atria beat simultaneously, and we're going to look at that conduction pathway in just a little while. Atrial kick is really important to be able to, if you will, push or kick blood into the ventricles and really fill them up so that when the ventricles each beat, they're going to push a goodly amount of blood either to the lungs or to the rest of the body. It adds 25% more blood to the ventricles. If we don't have atrial kick in a rhythm like atrial fibrillation, we're not going to have that extra blood there, and the patient is going to suffer with that decreased amount of blood to the ventricles going to the lungs, and then, like I said, going to the rest of the body. There's a movie here now showing you how the blood moves through the right atrium, right ventricle, pulmonic valve, in from the lungs, from the pulmonary veins, into the left atrium, through the mitral valve, and then out the aortic valve. So just have a chance to look at that and really memorize that movie and that moving blood. So if there's no atrial kick that provided that 25% extra blood, the blood can then stagnate because usually the heart is in atrial fibrillation. So the atria, if you will, are just quivering. They're not pumping and pushing blood at all. And that blood, when it stagnates, can start to clot. Those clots form, and if it's on the left side of the heart, we can have a stroke or a heart attack, or if it's on the right side of the heart, a pulmonary embolus. Most of the clots occur in the left atrial appendage. 90% of the clots occur here. This view also just shows you how darn muscular the left ventricle really is. So that is the high pressure side. So we've got this appendage in the left atrium that we're looking at. And a filter was developed called the Watchman filter, and it's put in under sedation and placed intravascularly. They usually go through an artery, through the left atrium, and then they set that Watchman filter, which will prevent stagnated clots from then migrating out and going to form a stroke. There's a movie here now, and you will see and hear the person talking about an ischemic stroke from stagnated blood from atrial fibrillation. So look at that left atrium. You'll see kind of a clot forming there, and then we'll go ahead and turn on that movie.
Where this happens, blood clots can form, and these account for the increased risk of stroke associated with AF. The problem with a blood clot in the heart is that some or all of it can break away and travel along an arterial highway directly into the brain. As the blood vessels branch and become ever finer, at some stage the clot or fragment of clot is going to be too large to progress any further and will block the vessel in which it is travelling. This means that the surrounding area of the brain can no longer receive oxygen delivered by the blood, causing the nerve cells to stop working and ultimately die. This complication is called a stroke, or more precisely, an ischemic stroke. Because clots that form in the heart may be quite big, They can block wide vessels that supply large areas of the brain. Consequently, strokes arising from AF may often be fatal or can cause temporary or permanent disabilities, depending on how long the oxygen supply to the brain is interrupted and which part of the brain
was affected. When a patient presents to us in the operating room, we have to get very quickly in and dissolve that clot. So we've got like a golden hour before that tissue in the brain is totally destroyed. This is a right-sided pulmonary embolus that can form because of that quivering right atrium. So because of the circulation, the clot's going to migrate to the lungs and it's going to get caught in a smaller and smaller blood vessels as the circulation proceeds. It will get stuck there, and then any tissue beyond that clot will die. This is a review showing you the low pressure and the high pressure side of the system, just for you to review that and make sure that you totally understand that. Let's talk about letters. There's some anatomy I want to show you. In the developing embryo, we have what's called a sinus node that develops very, very early. It's just an area of tissue that is going to be associated with initiating the electrical signal. It has nothing to do with our sinuses in our skull. It's just called the sinus node. So what's going to happen is that once the sinus node sends out the electrical activity, we're going to simultaneously stimulate both atria at the identical same time. And we're going to initiate that electrical signal and have those two atria cause that atrial kick that we talked about earlier. That conduction pathway is called Bachman's bundle. And I have a cadaveric cut to show you those wires, if you will, of nerves that connect from the sinus node to both atria so that they both fire and shoot blood or kick blood down into their respective ventricles. The activation of the atria by the sinus node is represented by what's called the P wave on the EKG. The signal is going to then progress down to the atrioventricular node. So that node is going to be right at the junction between the atria and the ventricles. Then it's going to proceed down the bundle of His, and it's going to split into a right bundle branch and a left bundle branch. And from there, that is going to proceed through these tiny little filaments called the Purkinje fibers that will cause the electrical activity to cause the heart to beat. Over the next few slides, I'm going to just let you go through them. They're going to be an electrical review. I want you to learn this anatomy and name these anatomical structures. Grab your piece of paper and write down what you see there, and of course you can always pause the video. Look for the question mark. We're pointing at that blue dot in the upper left as you see it. And then that is going to be the sinus node. I'm going to leave enough room so that you can pause. Let's go on to the next slide. These are the right and left bundle branches. So the patient is looking at us. The left side of the heart on this picture, if you will, is on our right, but the patient is looking at us. So we've got the right and left bundle branches. That anatomical portion is the AV node, the atrioventricular node. These fine fibers are called Purkinje fibers, and they just permeate all throughout the ventricular muscle. lastly have the bundle of His. These green areas are Bachman's bundles. They're just wrapped around both atria, you can see that. When the heart muscle depolarizes, we're really lucky that there's two different types of cardiac muscle, and it really differs from skeletal muscle and smooth muscle because fortunately we have two channels. We have a channel that is called a fast sodium channel. It allows rapid response of the cardiac muscle. And we also have a slow calcium channel that works simultaneously with the fast sodium channels to give a forceful and a sustained, non-rapid contraction of the heart. So that cardiac muscle is very different, as we said, from smooth and striated or skeletal muscle. Electrically then, we have atrial depolarization, which is again going to be that P wave. When the ventricle depolarizes electrically, it produces a wave that's called a QRS complex. We'll see all these again in just a bit. Then the ventricles repolarize, the sodium-potassium pump kicks in, and we see this uprise in the EKG, and that is ventricular repolarization, or the T wave. The sodium and the potassium pump. The pump is very strong, it's very rapid, it utilizes strong phosphate bonds from ATP that are made in the mitochondria. You'll notice that a little bit of electrical imbalance occurs in that 3 sodium ions are kicked out and 2 potassium ions are kicked into the cell. Why don't we see a wave for atrial repolarization? Remember we said just below this picture that that T wave that we're going to see in just a bit is the ventricles repolarization occurring. Why don't we see a wave for atrial repolarization? And the reason is that it occurs during the QRS complex. So let's look at these together. When we have that electrical sinus node Bachman bundle electrical signal, it's going to produce the P wave. That's going to activate the atria. Then the ventricles are going to activate, and that produces the QRS complex. And then the T wave is the ventricles repolarizing, getting ready to fire again, burning ATP to get the electrical imbalance to occur on either side of the cardiac cellular membranes. The isoelectric line is the line that occurs at the baseline, if you will, of each of these waves. So in some cases, we're going to see the isoelectric line that's going to be higher than the T wave, and some that are below the level of the T wave. But everything that's kind of represented there by those long spaces in between lines, that's called the isoelectric line. So here is a normal isoelectric line. There's some intervals that I want you to know about too, and they totally follow the letters that we've been studying. There's the PR interval. I know it looks like it's going to the Q, but it's called the PR interval. And then there's the QRS complex. There's an ST segment. And then there's a QT interval. And different drugs can interfere with this QT interval and can send the patient into some lethal rhythms. I just want you to basically know what's going on with each of those different intervals. Let's talk about EKG tracings now. Look at the paper, look at the monitor. But first, let's talk about the paper. There's some things that I want you to see. Notice that it's built into or printed in big squares, and then there's 5 little tiny squares that make up the width and the height of each of the big squares. So one of the big squares represents 0.2 seconds. And that's outlined there by that red square. The little tiny squares are 0.04 seconds. So there's 5 of those little tiny boxes within one big box. So if we do 0.04 or 0.04 times 5, we've got 0.2 seconds. Same thing. But Dr. Dubin has a nice, slick, quick way for you to look at an EKG if you're looking at a tracing, which you're going to be doing with your exams and some of your practice strips, to look at it and quickly discern what the rate is. So what I'm going to want you to memorize are the numbers as follows: 300, 150, 100, 75, 60, and 50. And I just want you to learn those cold. So that's going to take some memorization, because we're going to be looking at some strips and you're going to see how neat and slick this is to be able to figure out not only the rhythm from the strip, but you're going to be able to figure out the rate very quickly. So memorize these numbers. As we go further along, I would learn also 43 and 37. These are going to be your beats per minute. So 300, 150, 100, 75, 60, 50, 43, and 37. Just memorize those. So what you're going to want to look for an EKG is, when you're evaluating one, is you're going to find a QRS complex that's right on the line, the big heavy line of the big squares, the 0.2 second squares. So you'll find one that's there, and you'll have to look throughout the strip to find it, and that is your start. So the next line over to the right, if that's where the next QRS complex is, will be a rate of 300 beats per minute, and so on. If the QRS then falls at the 150 mark, it's 150. If it falls between 100 and 150, it might be 100 or 120 beats per minute. But that's why it's so easy to just memorize these numbers. So if we were to do that with what we see in this strip, we'll start with this QRS complex and go across and do our counting the way that Dr. Dubin showed us. So the way, if we go with our 300, 150, 100, 75, 60, 50, 43, 37, you can see the heart rate is a little less than 37 beats per minute. It's just a really neat way to be able to quickly figure that out. The old way would have been to have to take a calipers, find out the distance between the QRSs, and then do some multiplication, knowing how big those big squares are and the little tiny squares, the amount of time that they take. So here's a practice strip. Take your time. If you have to, pause the video. We're going to start with a QRS right there on the large or thick line. So if we use our mnemonic, you can see that the rate's going to be about 150 beats per minute. Let's do another strip. That QRS is pretty darn close there where I've got the start signal. So let's count across, use your memorization to find the rate for this patient. So using the mnemonic, we're about 75 beats per minute. It's important to know where those EKG patches or leads go. So for a 3-lead EKG, we've got the white, the red, and the black. And then to not put those here, this is kind of meant, hopefully, that you'll find that a little bit funny. Don't put them there. The mnemonic is white to the right and smoke above fire. We've got the white to the right side, and that can be even out on the arm. It doesn't have to be on the shoulder. And then The smoke is black smoke rising from the red fire which is on the ground. Let's talk about rate and rhythm. This is what's called a normal sinus rhythm. You see that word sinus again, so we know that the beat was initiated in the sinus node. It's called normal because there is a P before every QRS, so look at that. And for a normal adult human, not a child, adult human, it's defined as 60 to 100 beats per minute. It's a regular rate. You can see all the QRS waves going equally between each beat. There's a P before every QRS, and you can see that we're at about 75 beats per minute there. Sinus tachycardia in an adult human is a P still before every QRS. That's what makes it sinus. And the rate is greater than 100 beats per minute. For ACLS, just to let you know, an adult is defined as anyone usually over 8 years old. There's usually armpit hair developing in the men and breast development in women. So that anything older than that is considered an adult. Sinus bradycardia is going to be slow. There's still a P before every QRS, and we're less than 60 beats per minute here. When we talk about rhythm, we have a regular rhythm, and that's going to be something like a beep, 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 just totally regular. An irregular rhythm is another descriptor, and that's where we have something similar to a beep, 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 totally, and it just doesn't have any kind of rhyme or reason to it. And then we have a regularly irregular rhythm. Take a look at the EKG and listen to the sound. I think you can hear that it's just not a constant regular rhythm. Let's read an EKG. And these 4 questions that you have to ask yourself before you read every EKG, even if it's on the monitor. So I would memorize these 4 questions, just like you memorized those numbers before. And of course, the anatomy of the heart and the electrical conduction system. So the first question is there a P wave before every QRS? The second is to figure out how fast the rate is or how slow the rate is. The third question is, what is the PR segment? You're going to look at that PR segment length to see if it's small, getting longer each time, or even longer. You're going to look at each of those PR intervals. And then you have to think, knowing with the anatomy that you just looked at, what electrophysiologically is causing this EKG. As we said at the beginning of class, there's 2 definitions. There's arrhythmia, which means to me no rhythm whatsoever, or dysrhythmia, a bad or difficult rhythm. And as you can see, those are the words that I'm using throughout. So we've got these basics down, and if you need to review those over, look at your notes, make sure you understand it, because I am going to really mess things up for you now. We're going to put some twists into things and help you interpret your EKGs for your patients' electrocardiograms. Some rhythms you're going to recognize right away. Some you're going to have to look through and ask your 4 questions and analyze what is going on with that rhythm, what is causing that. And there are your 4 questions again. So let's go ahead and name this rhythm. This is one that you should recognize. Take the time to look at where the QRS is. Look to see if there's a P wave before every QRS. Look at the PR interval, and then electrophysiologically, what is going on with that heartbeat. So name this rhythm. And this is normal sinus rhythm. It's one that we've looked at before. Let's look at this rhythm. I think you can tell right off the bat what rhythm this is going to be. Let's find the QRS and do our 300, 150, 100, 75, 60, 50, 43, 37 thing. So that rhythm is sinus bradycardia. So let's talk some, while we're talking about bradycardia, let's talk about physiologically what is going on with bradycardia. One of the important systems in our bodies is our autonomic nervous system. To me, autonomic means automatic. It doesn't have to be anything that we can control with our thoughts, and it functions to integrate or to cause an electrical signal or stimulation and then chemical stimulation to the viscera throughout the whole body. So a lot of our body's tissues. And it's broken into two systems or sides within the autonomic system. There's the parasympathetic side and the sympathetic autonomic nervous systems. And they have different anatomy and they have different neurotransmitters. It's powerful, the autonomic system. It can cause a lot of changes in the heart muscle, in contraction of muscle itself, in our heart rate, all kinds of stimulation. We're going to look at the anatomy basically here in just a bit. And these two systems work together and talk to each other to be able to keep the organs in a state of homeostasis or normalcy. So the two systems counterbalance each other. The autonomic nervous system, where we're going to represent it as the parasympathetic side, then the sympathetic side, and the neurotransmitter for the parasympathetic side is acetylcholine. The neurotransmitter for the sympathetic side is going to be norepinephrine. So these are the counterbalances to each other. Here's a diagram that shows you basically the parasympathetic nervous system. There's a bunch of different cranial nerves involved here, and it has the effect of, especially with the vagus nerve, cranial nerve 10, of affecting a lot of major organs. Slows the heart rate, it stimulates saliva, constricts the bronchi, which is not good if we want some good breathing. It stimulates peristalsis. So we get a lot of relaxation here, slowing the heartbeat, digesting, breathing slowly, and it stimulates the release of bile and it contracts our bladder. A much better diagram showing you the cranial nerves that are involved in the parasympathetic side. You can see we've got 3, 5, 7, 9, and 10. That vagus nerve, number 10, is going to be our biggest contender when we're treating a patient under sedation or when we've got a problem with an EKG like bradycardia, because it's going to release acetylcholine at the heart receptors and it's going to really slow down the heart. So the big nerve, again, is cranial nerve number 10, the vagus nerve. Vagus means wandering. And the molecule acetylcholine is right here. So we're going to have the bradycardia, as I said, right with the parasympathetic side. Here's just another diagram of the parasympathetic nervous system. I think we pretty much repeated that and beat that one to death. I really want you to learn that one. It's important, along with the sympathetic side. So look at how different the anatomy is going to be compared to what we're going to see with the sympathetic side here in just a bit. So the nerve terminal is going to release vesicles of acetylcholine across the neuroreceptor membrane, and then it's going to attach to receptors on the other side of the muscle, and then it's going to cause the stimulation that we get with parasympathetic stimulation from acetylcholine. Look at how different the anatomy is of the sympathetic nervous system. We're going to have it organized and distributed to each of the different organs that we talked about with the parasympathetic side, but notice that there's a sympathetic chain down the side of the spinal cord. Down about in mid-belly, we have the celiac ganglion, and then we have sympathetic nerves that are distributed from there. It's not like the vagus nerve, but notice it's going to the same organs. It's going to have the opposite effect of that parasympathetic side, and we're going to have norepinephrine stimulating right here, also on the neuromuscular junctions of the heart and all the other organs. Another different diagram of what the sympathetic side of the system does. It's going to have the complete opposite effect. We see the anatomy of the sympathetic chain, and there's that molecule norepinephrine. And there it is being released across the neuromuscular junction, having its effects then on the sympathetic receptors of all the different organs. This is a comparison of the parasympathetic and the sympathetic sides. So notice it has the complete opposite effect between the two systems, the norepinephrine and the acetylcholine. So this is how homeostasis is obtained, because the body receives feedback from each of these organs to see if it needs to speed up, slow down, or whatever stimulation is causing it. So we stay in a nice, stable, and balanced state called homeostasis. So norepinephrine is going to cause then tachycardia. So the drug that we use to rapidly treat in a code situation or someone that's having symptomatic bradycardia is going to be the drug atropine. Atropine can either come in one of the injectors that you see on the left, you'll just have to assemble it, or there's vials of it that we can drop the med and inject intravenously. Atropine is called an anticholinergic. So let's look at some rhythms now. Remember the 4 questions. I want to show you, because you're going to rarely see this, but your younger patients, if you have them hooked up to an EKG, will have something called sinus arrhythmia. We don't see it that often. If you look to the left of this strip, you can see that the heart's beating rather slow, and then you'll see the waves are closer together. So when they take a big deep breath, or they're just breathing normally, and this is usually a young adult or a young child, they're going to have this sinus arrhythmia because it stimulates the vagus nerve and it slows the heart down. And then after they exhale, the vagus nerve isn't stimulated as much and the heart rate goes up to its normal rate again. So I just like you to see that, to see how all this electricity and all these different neurotransmitters work. So it is still considered a normal sinus rhythm with this sinus arrhythmia due to the breathing. And you can see it does speed up and slow down. So an atrial premature contraction, it's an early PQRST, and it's not keeping up with the regular rhythm, and I want to show that to you. If you look along the top, I'm going to turn it on in just a second. If you start on the far left and look, you'll see that there's pretty much normal spacing there. And then about close to the middle of just to the left of middle, you're going to see an atrial premature beat. So there's a premature P, QRS, and T complex. So let's call an APC, or an atrial premature contraction. I'm going to go ahead and turn on that movie.
Yeah, they're down here.
And if you listen to the heartbeat, you'll hear it. Sorry about the talking in the background.
What did you say, Sandy? What?
So when you're listening to the pulse ox or you're listening to the beat of the EKG while you're doing your dental work, you'll notice that you'll hear just a regular, constant beat, beat, beat of the normal sinus rhythm. But an APC will mess up that regularity and it'll occur just a little bit too early. So that's called an APC. Name this rhythm. So look at it, find a QRS on a solid line, look at your 4 questions, and tell me what this rhythm is. And that is sinus tachycardia. P before every QRS. The rate's about 150 beats per minute. You can see that they are all regular rhythms, that the QRSs are all spaced out regularly, but it's a fast rhythm. Remember, it's going to be greater than 100 beats per minute for an adult. I want you to look at now the PR interval. Remember, that's the interval where the start of the P wave is to where the R wave is. And I know it's kind of a wide R wave, but look at the distance between that first hill, if you will, called the P wave, where the QRS complex is. So look at that PR interval. Compare it to the sinus rhythm. So you can see that that PR interval in the top strip, that PR interval is stretched out longer than a normal sinus rhythm. And this is called first degree AV block. So if the PR interval is abnormal and we still have a P before every QRS at this point, it's called first degree AV block. So we're going to have some atrioventricular conduction problems, and it's going to stretch out before the signal reaches the ventricles, the bundle of His, the left and right bundle branches, and the Purkinje fibers. It's stretched out long and it's abnormal, so it's called first degree AV block. Look at this PR interval. Take and start with your first QRS complex on the left. Look at the PR interval. You notice it's pretty close together, like a normal PQRS, a normal PR interval like you would see in a normal sinus rhythm. Notice that then the second QRS complex, the PR interval is stretched out. For the third QRS interval, the third QRS wave, we've got it really stretched out. So we're short, medium, long, and then the next beat, we don't even have a conduction to the QRS, to the ventricles. So this is called, if you look through these slides, you'll see PR is getting longer, 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 and then there's a drop beat. And then we start that cycle all over again. We have short, medium, longs. And this is called second degree AV block, and there's 2 types here. This is called type 1. The name that a lot of people still use is Wenckebach, and the more modern name is Mobitz type 1 AV block. So it's Mobitz type 1 dysrhythmia. So if you're going to take an ACLS class, you'll have to know these EKG rhythms. So look at the 4 questions. Look at this PR interval. You're saying, well, that looks pretty normal. But you see that every other wave is blocked, that the P waves are evenly spaced, even though there's not a QRS after some of those. That PR interval is still the same, but there's a QRS that's dropped. This is called second degree AV block type 2. So it's also called Mobitz 2. Notice that The PR interval stays the same. It doesn't get short, medium, long, extra long drop like we saw with Mobitz 1. So this is Mobitz 2 or second degree AV block type 2. Let's look at another strip. Notice that we have P waves that are just marching along. They have no regard for the QRS complex at all. It looks like it does, but if you take your fingers or take your eyes and look at the P waves, you notice that they're marching from left to right, out in order, from left to right, and that they're not even talking to the ventricles whatsoever. So there's no communication there. There's no rhyme or reason for them to have even talked, in this case, to the QRS complex. It's just marching along that P wave all by itself, and everybody's doing their own thing. This is called third degree AV block, and this, as you can imagine, is quite serious. It's going to require an artificial pacemaker at this point in time. So there's a total disconnect between the P that's occurring from the sinus node. It is not at all talking to the conduction system inside the heart. Notice that these P waves are going very, very fast, and that they're sharp. They've got a peak to them. And that they're still regularly spaced QRS complexes. This is called atrial flutter. Not seen too commonly, but I want you to see the waves. It's going to be different from atrial fibrillation. And it is a precursor to hemodynamic instability. So atrial flutter is not good for the patient. Here's your 4 questions again. Make sure you memorize them. This is going to be atrial fibrillation. We've got quivering atria, both left and right, and the EKG still hooked up in its normal positions with white to the right and smoke above fire. So if you will, we've got quivering, just fibrillating atria. So no blood is being pumped. We talked about no atrial quick kick, giving us that extra 25% of blood. So we've got real problems for the patients here. Some patients live with it. Some need to be sedated and shocked back into a sinus rhythm. They all require going on a blood thinner of some kind so that the clots don't form. And then sometimes a pacemaker is then put in. So atrial fibrillation. That right atrium, and it occurs of course in the left atrium, there's waves going every which way. It's just chaotic rhythm that we have up in the atria. And in just a bit, we're going to see that same chaotic rhythm down in the ventricles. This is called these odd looking QRS waves. I know that the P, QRS, and T are upside down in this, but these odd looking waves are called ventricular premature beats, or VPBs. They're also called PVCs, premature ventricular contractions. And some of us get those whenever we haven't had a lot to drink in the way of fluids, and it'll cause kind of a thump, or there might not even be any blood pumping when a PVC occurs. So we look out for those because they could be trouble in certain patients. A lot of people have them and they're not even aware that they have them until we hook them up to an EKG. So we have this pseudo QRS complex there, and this is a VPB or a PVC. This is a lethal rhythm. It's called ventricular tachycardia, or VTAC. And notice that each of the waves is in one pattern. So this is called monomorphic, made by these waves. The heart's beating somewhere in the area of 250, 270 beats per minute, which means that there's not a long enough diastolic filling time. The heart muscle is using energy like crazy. It's needing oxygen like crazy. It's giving up carbon dioxide, and it's not getting enough. This is polymorphic. Notice it's kind of an in and out or a thin wide pattern of VTAC. It's also called torsades de pointes, and we treat that in ACLS differently than we do the monomorphic VTAC. We would give the person magnesium in this case. Not anything that's on your test, but I'd just like you to know the difference between monomorphic and polymorphic VTAC. There's the 4 questions. This is another lethal rhythm. This is VFib. So there's no pulse going on here. The heart is quivering. The ventricles are quivering. The patient is going to die unless we take some intervention and start CPR and early defibrillation. Start an IV, get some epinephrine started on this patient. So this is VFib or ventricular fibrillation, a severe lethal rhythm. That same chaotic electricity going through and around and all over the ventricles. So when we shock the heart with our paddles or our AED, what we're doing is we're not jump starting the heart. What we're doing is we're knocking out all these crazy electrical activities that are occurring and just causing all this chaos and all this fibrillation. So if we knock it all out, we hope to then reestablish a sinus rhythm. Again, the paddles or the electricity do not jumpstart the heart. It erases chaos. An agonal rhythm, there's a elevated, severely elevated ST segment here. You can see it way above the line. This is a severely ischemic heart. No blood is pumping, and this is just a lethal rhythm. The person is approaching death. They may not even go through the stage with the agonal. They may progress on to flatline or asystole. This is supraventricular tachycardia. So this is going to be started in the area above the ventricles. It can be an electrical stimulus, not necessarily the sinus node, but some other errant tissue, and it goes into a rate of just suddenly into the 270s, the 250s. It'll just take off like a rocket, and that's called supraventricular tachycardia. And if it happens suddenly, that's called paroxysmal supraventricular tachycardia, or PSVT, and we treat that in ACLS with adenosine. There's a whole algorithm for that. See if you can figure out the rate here. You can see we're pretty darn close to 300 beats per minute. Heart's not getting enough oxygen and getting rid of waste and getting the nutrients, the ATP it needs to fire the cells. Paroxysmal PSVT on the left, converting then to a sinus rhythm. I know it's not the most beautiful sinus rhythm, but they were probably shocked out of their PSVT or given the adenosine something through their IV, and it caused them to go back into that sinus rhythm. So paroxysmal just means sudden. Notice here that we have quite a large, away from the isoelectric line, ST elevation. So this is a person having a STEMI heart attack. ST elevated MI or ST elevated myocardial infarction. You can see that ST segment is way above isoelectric. This is what a pacemaker looks like. It's going to be an artificial P wave, and your monitor will pick it up as what's called a pacemaker spike. And those are set by the manufacturer. They have a way to talk to the pacemaker magnetically, with something that's placed above the chest, and then the computer talks to and sets up the pacemaker. So this is put into a sinus rhythm that's artificial, and those vertical lines going up and down are called pacemaker spikes. Just to show you, VTach, then a shock, and then the person is hopefully going to come back into a sinus rhythm. And if you look to the right, you're going to see that sinus rhythm come back. So on the left, we've shocked the patient to erase the chaos in the VTach, and it's converted on its own back to a sinus rhythm. So this is a code situation. And there is the conduction through the heart to erase the chaos. I just want you to see other pacemaker spikes. We don't have the monitor set to pick up the spikes, but you can see it's really different looking. It is not an elevated ST segment, but just know that it is an artificial P wave that's being caused by the pacemaker. Then I'm going to go and turn on a special thing on our monitor, and your monitors will have it also, to pick up the pacemaker spikes. So those white lines are when the pacemaker fires. Notice that we have a sinus beat, then we have a PVC, a premature ventricular contraction, then a normal sinus beat, then a PVC, a normal sinus beat, and it's a PVC. So it's every other beat, and this is called bigeminy. It's after one QRS complex, and it happens each time. This is called bigeminy. If it occurs on the third beat, it's called trigeminy. So bigeminy, it happened on, we had the normal first beat, the second beat was a PVC. So the third beat here, the PVC occurred, so that's trigeminy. And notice that it looks like it's happening very regularly. And then lastly, if it happens on the fourth beat in this regular pattern, it's called quadrigeminy. The next slides are going to be practice rhythms for you. So I'm going to show them up on the screen. You can put them on pause and you can read what's on the screen. Take your time, use the 4 questions. If you have to, pull up your notes or write them down and go through that way of going through the rhythms to try to figure out what is happening here with each of these rhythms. There's the 4 questions. There's another normal sinus rhythm. Use your 4 questions. Notice that the PR rhythms are staying the same and that we've dropped QRS complexes. So this is going to be second degree AV block type 2 or Mobitz 2. PR stayed the same. Notice that the PR is quite long and that there's a P before every QRS. So this is first degree AV block. This is going to be atrial fibrillation. Notice we don't see any P waves. Notice that the P waves are marching along. Some of them got caught up in that QRS complex kind of to the left there, but things are just marching along electrophysiologically. Nobody's talking to each other. So this is third degree AV block. This is ventricular fibrillation. Notice those P waves. So there's atrial flutter. Notice that the PVC or the VPP is occurring every fourth beat, so that is going to be quadrigeminy. Here's a patient of mine up on the monitor that had quadrigeminy. So if you study those, if I see them on a patient, I'll take a picture of them in the OR. Notice it's happening on the fourth beat. So we have 3 normals, and on the fourth one, and this occurs regularly, we've got quadrigeminy. So we've got sinus tachycardia. We don't have the greatest P complexes here, but notice that the rate is pretty even and pretty slow. So this is first degree AV block. So we just have a long PR interval, and I know that these are not the best P waves, but some of them, they show up pretty well. So don't sweat it if you don't see it that easily. On the very far right, you can see after the T wave, not the very furthest right, but the 2 QRS complexes on the very far right, just before you get to the end, you'll see there is a P wave there, and it's a long PR interval before that last far right QRS complex. So there's supraventricular tachycardia with ST elevation. And we've got sinus bradycardia. P before every QRS, a nice, really slow rate. Here's some sharp peaked P waves. So this is atrial flutter. And this is some atrial flutter. It's not as even. The QRSs are not even because there's some electrical signals that are not being conducted down to the QRS, down to the ventricles. I think you can see that in and out pattern. You can tell it's VTAC, but you can see it kind of going in and out as big, wide, and slow or narrow. So it's kind of going in a circular motion in the ventricle of the heart as the VTAC progresses. So this is polymorphic VTAC, also called torsades or torsades de pointe. So torsades means kind of a rotation or a twisting. This is going to be 3rd degree AV block. The easiest way to look at these are when you're looking at your P before your QRS, look to see if they're spaced out evenly. If they're spaced out evenly, look to see what they hit and kind of don't look at the QRS complex because it's not talking to the QRS complex anyway. So this is 3rd degree AV block. That's going to be trigeminy. So it's a PVC and it's regularly on the 3rd wave. If you had marked down PVC on an exam, I would have given it to you. But if you mark down that it's trigeminy, that's even better. This is a pacemaker insertion, and we see this nice artificial P wave being generated, causing a nice rate. They probably set it for 70 beats per minute, but the person's at about 74 beats per minute there. is going to be Mobitz 2. We just have a same PR interval with dropped waves. We're going to have ventricular tachycardia here. I would call this monomorphic ventricular tachycardia. Look at your PR intervals here as a hint. So use your 4 rules. And this is going to be second degree block type 1, AV block, or Mobitz 1. And the other name for it, remember, was Winky-Bach. On the right, look at the rate, see if you can figure out what the rate is. Notice it's going very fast and it happened suddenly. This is PSVT, paroxysmal supraventricular tachycardia. We've got a sinus rhythm and we've got a PVC that's formed. Look to see how it's distributed and what pattern it's going in. So that is bigeminy. So on the second beat, every second beat, we have a PVC or a VPB. Premature ventricular contraction or a ventricular premature beat. Here's a patient that had both quadrigeminy on the monitor and bigeminy. So they were alternating between the two. So actually, obviously got some conduction problems here from the sinus node down through the system, through the conducting tissues, down to the ventricles. Here's another view of bigeminy on a monitor. You can see that there's some tall peaked P waves on the left. That's probably going to be atrial flutter, and then it converts to atrial fibrillation. Now, something I didn't mention before is the QRS, or the ventricle, has its own native rhythm. So it will beat even without any signal from up above, from the sinus node or any of the conduction. Notice it's an irregular rhythm, and it usually is set at, from what I have read, at about 37 beats per minute. So obviously the patient's not going to live real well with that. So we've got to do some interventions to be able to have the cardiologist get them into a regular beat that's pumping blood and not going to cause any clots or progress to something worse like VTAC or VFib. So this again is another view of third degree AV block. These blocks are really rare, but this is where you're going to use your judgment and your 4 rules to go through each and every EKG that you're reading. Some of these you can just pick out right away, looking at each of the different leads that they use for a 12-lead EKG. I think you can see that this person is in monomorphic VTAC or ventricular tachycardia. I would have given you credit for that. Don't pay any attention to the red arrow. Look at the signals and look at what's going on with the P waves. So this is AFib or atrial fibrillation. This is just a monitor view of a person that's in AFib, so I took a screenshot of that. And that is the end for your course. I appreciate you taking the course. Here's some of the references that I used, and thank you very much.